Hi, everybody, and welcome to Chicago. It's really great to see a lot of familiar faces in person and not on a Zoom screen. Of course, I have the habit of looking at the screen because that's what we've done for the last 2 years. But I want to, first of all, before I get into the specifics of the talk, say a big thank you. As Tracy mentioned, I had the privilege and honor of being the chair of the Professional Advisory Board for Lennox-Gastaut Syndrome Foundation. And it is my last meeting, so it's a little bittersweet, a little sad. I'll try not to get emotional. But just to see where the foundation has come from when we first kind of started talking about a lot of the ideas that we're going to see in fruition today has been an amazing opportunity. I still remember the meeting we had in Long Island many years ago now, talking about some of the challenges that we have in the field. Some of them still exist today, and I look to this audience to hopefully help solve those issues. But again, we're coming a long way, and there's a great focus on a bunch of people with epilepsy and their families that need our help. So I'm going to give you a quick overview of the clinical state of where we are in LGS. By no means is this going to be a detailed presentation or one that I think that you would get specifics out of. I'm not a grantee, so I really want to give the time to those folks to talk about their amazing research, but just to kind of set the tone of where we are today and where we need to go. Here are my disclosures. You know, when we talk about Lennox-Gastaut syndrome, Tracy mentioned, you know, what it is, and we'll get to the specifics, but don't forget that we're talking about an epileptic encephalopathy. In fact, we're probably talking about a very hallmark version of that, other than infantile spasms. And now what we know is lightning years ahead of what we did back then as it relates to epileptic encephalopathy. But the difference in what's challenging is it's not just the epilepsy. These features, the changes on EEG affect the cognition, the development. So it's, in my opinion, more troublesome when you see this picture because of the package that it keeps. But remember the difference between the two, and we can debate it all the time, but technically, you know, cortical malformation by in itself is not an epileptic encephalopathy. Now, sure, could that cause or be an etiology of it? Yes, but again, it's the deficits are there because of the epilepsy itself. As we know, it can be a very challenging diagnosis. You know, we talked about that there are multiple causes. It can present very differently depending on what age. If it's not recognized in early ages, those features will look different. Multiple seizure types are obviously present, and that's part of the diagnoses, which then can also make a challenge because it's sometimes not on people's radar. It's often confused with other diagnoses. Now you may say, well, what do you mean by that? I mean, when you have changes to your brain and you have learning issues or regression or other cognitive problems, we often want to blame something else other than perhaps the actual EEG features or the epilepsy. And in this case, obviously, they're linked directly. There's also disagreement on what exactly is LGS and what criteria should be used, and is it important to actually make that criteria. I hope this room doesn't need convinced that the name LGS is important and it's an important diagnosis. But why is it important for those that aren't convinced? Well, we now know we have FDA-approved treatments. Those happen because there's a diagnosis of LGS. Whether you agree with it or not, these medicines and these trials happen in a group of patients because of LGS. Now we can focus, we can monitor data, we can capture things over time, we can learn from the group of people who have some common features and also those that have different features. We also think that if you recognize and get on the right treatments, that you can have better outcomes. And we'll talk a little bit about that, but again, a very important concept in our treatments. Well, you heard about Tracy's research opportunities. Those exist because of the foundation. Those other grants that exist outside the foundation are for LGS, and specifically, that can be of great benefit. And most importantly, in my opinion, there's a great foundation. If you have a patient that has LGS and you have not connected them to the foundation, you're really doing them a disservice. And so it's very important that they're linked because of all the amazing resources, all the amazing educational opportunities, and most importantly, the support system that goes with it. There are people out there that will help, especially for those that are new in their journey. So we know that a lot of this is what causes LGS. We know a lot of this, right? That they have Now the data shows it's about up to 75% have an identifiable cause. And that's really likely because of the advent of genetic testing and the increase in access of genetic testing. Heather Meaford, who's on the board as well, is a big reason why we're in this situation, because she's contributed, amongst many others, to the literature and showing us that there's more genetic etiologies associated with the LGS features. Obviously, we talk about the structural changes to the brain. But again, those structural changes may not always lead to the same pathway or network development that we see in LGS, and we have to figure that out why. Same thing with the genetic variations. You can have two people with the same genetic variation, and they may not both have LGS. And then we talk about the previous history, or that pre-LGS, and up to 20 to 30% having a history of infantile spasms. So when we talk about structural causes, we talk about brain asphyxia, HIE, TBI, infections, brain malformations. But again, all of these things may be different but lead to a common pathway, but not in every patient. The genetic list is getting longer and longer, like I mentioned. Here are some that we are seeing today, and we'll talk about in a few minutes why that's super important and where I hope we see more growth and opportunity. The other big thing is that we're also seeing better access to exome sequencing and now even genome sequencing. For those that were able to attend the Child Neurology Society meeting, we did a grant through the Child Neurology Foundation where we were able to provide whole genome sequencing to those that had previous genetic testing but no diagnoses. And we were able to find a significant number of those with whole genomes to be diagnosed. Ann Padure helped me with that, or helped us with that project as well. So we think that's another area. The current state is getting access to genetic testing, but it's not always easy for all these patients. What about unknown causes? What do we know about that as it relates to the current clinical state of LGS? Well, we know that more likely these children may be having mild or normal development at onset. They may start a little bit later. Normal imaging and normal examinations. They may not have dysmorphic features. They are less likely to have infantile spasms, and perhaps they have better treatment outcomes. But when you look at the studies on these patients, 55% had tonic seizures. Now, we would like to think, and I think most people would agree, tonic seizures upon awakening is a very common feature, obviously, that we see in early onset LGS. But in this study, where they had unknown kids, only 55 had tonic seizures. 60% had generalized tonic-clonic seizures, and their EEG frequency varied. Now, the 5 hertz is a little misleading because, again, that would be exclusionary for their diagnosis. But what's important is there's opportunities to learn. So there's gaps in the knowledge as it relates to those that present with LGS earlier or in more typical fashion compared to those that present later. What about treatment advances? Where are we currently as it relates to the state? Well, many of the folks that are in this room have contributed to that. Fenfluramine is in various forms of trials for potential approval in LGS. As you all know, it's approved in Dravet syndrome. Perampanel has studies in various forms, cenobamate, and the list goes on. But we have also had some recent FDA-approved medications that have helped in our journey for treating seizures as it relates to LGS. One of the first plant-based purified form of marijuana was approved in cannabidiol for the purposes of treating seizures in LGS, Dravet, and now tuberous sclerosis. And that's an FDA-approved medication. We also need to consider where we are on gene therapy and where that potentially can lead us as we move past our current clinical state and what potential associations that have with LGS. I think that goes back to obviously the importance of diagnoses, especially in those that have unknown. Another current area is, again, when I mentioned getting access to that testing, is making sure we in this room are getting the genetic testing performed on our children who have LGS of unknown etiology, so we can really learn together and perhaps develop treatments that target the actual gene versus the seizures and the consequences of those seizures. What about neurostimulation? We're going to hear a little bit later from John Archer and some of his work. I'm very impressed and very excited about this work because I think there's a lot of potential. We know vagus nerve stimulation has shown to have some efficacy and safety, obviously, in the treatment of seizures for LGS. In the AAN guideline, they specifically mention that it could be an option for children and adults with LGS. But what about beyond those that specific device? What about the central median nucleus implantation of the RNS? And what about potentially the DBS in that same location? What about other targets in the thalamus? If we think the thalamus is part of this important part of the network development, propagation, or cohesion, I don't know, but whatever we know, we feel it's a part of it. And if that's the case, how are these targets potentially useful for us in augmenting the seizures and potentially the developmental outcomes for our patients with LGS? Lastly, I want to touch about a couple things that's on the pipeline. Sandy Lamb, who's a neurosurgeon here in Chicago at Lurie Children's, and Ann Berg, who also is here in Chicago, submitted a grant that Tracy and I are both a part of through the PCORI grant to develop clinical phenotypes for LGS using data, the PHYS databases, or PEDSNet databases, I'm sorry. And then we're going to look at evaluating outcomes in various medicine treatments versus some surgical options. We're also going to get some survey information on these patients and their families, so we finally can start to learn about this trajectory and what treatments perhaps are better than others for certain subtypes of kids and adults with Lennox-Gastaut syndrome. So we are very excited about this grant and the opportunities that it will bring this field. But many questions remain, many questions that I, again, hope folks in this room and beyond will start to answer. When we had our meeting of the minds, we really had a great and robust discussion and came up with some awesome ideas. But those ideas need to come to fruition. They need to be made into research grants. They need to be made into clinical trials. They need to be made into outcomes that improve the lives of our patients with LGS. So will genome testing help? Should we have better access to genome testing? How do we get to that better access? What sort of partnerships can we create as it relates to getting better access? What about learning of the different etiologies with the same network? I mentioned that obviously different etiologies can present in various forms that may not always lead to the same pathway or specific EEG findings. Why? Why is that the case? How can we predict LGS and stop it before it happens? How can we augment the future of these patients knowing what we know now of the road that they'll lead? And how can we make their lives better? What can we learn about the natural history? One of the hard things about LGS and LGS natural history research is, again, these different etiologies. So when Tracy mentioned secondary 2, that was a very important concept we talked about early on many years ago in that meeting in Long Island. It was very important that you say specifically why you have LGS for two big reasons. We can then learn from each common pathway to see if those etiologies have something that's different than other etiologies. And also, again, if you say secondary 2 and you don't know the answer, please keep looking until you find that answer. And then we have to also understand, why does this phenotype exist and what can we do to prevent it? And where do we start to help prevent that? So I'll continue to do a lot of work in this field. I'll continue to fight every day for these patients and their families and hopefully contribute to the research that's done. But none of that can be done without the great work of Tracy and the colleagues at the Lennox-Gastaut Syndrome Foundation. So I want to say thank you. Thank you again for this opportunity. Thank you for letting me be a part of this awesome organization and watch it grow. Obviously, I'll stay very involved. You're never going to get rid of me, but it's been an honor to be a part of it. So thank you.